Hello, everyone, and welcome. My name is Joe Caramelli, and I oversee grand rounds for the Department of Psychiatry and Behavioral Sciences. Thank you for joining today. This is our first grand rounds of the academic year here, and we're very excited to start the 2022-2023 grand round series. We'll try to have grand rounds most weeks between mid-September to mid-June. And there's been a couple of changes to the series this year. I want to encourage you to write in comments or questions in the chat or the Q&A, and I could go through those with the presenter at the end. I also want to comment on the core grand rounds team, which includes Samhara Braha on coordination and communication and Mike Walker on technology. We do record and archive all the grand rounds presentations on the department website under grand rounds. Two sources of funding for grand rounds include the Ripley Fund and the Garvey Institute for Brain Health Solutions. We have a new evaluation for grand rounds this year, and I'll put the link in the chat towards the end, and I encourage you to complete that at the end of the presentation today. You're always welcome to write to me with suggestions for topics or speakers or for any overall comments or feedback. And now I'll introduce today's presenter. Now, today's presenter is Dr. Christine Moutier. And for almost a decade, Dr. Moutier has worked as the Chief Medical Officer of the American Foundation for Suicide Prevention, and more recently was appointed Clinical Professor of Psychiatry at Columbia University. Dr. Moutier has sustained a dual and I think related focus on suicide prevention and clinician well-being. With prior work as an Associate Dean for Student Affairs and Associate Dean for Medical Education at the University of California in San Diego. And while at UCSD, Dr. Moutier also worked clinically for over 10 years on a hospital service, which she directed, and in the outpatient clinic. Now, Dr. Moutier has presented widely, internationally and nationally, including in the White House and on CNN, on the topic of suicide prevention, and has received many awards for this work, including the Media Award from the American College of Neuropsychopharmacology. Early in the COVID-19 pandemic, Dr. Moutier wrote the article, Suicide Prevention in COVID-19 Era, Transforming Threat into Opportunity, which was published in JAMA Psychiatry. And we are very fortunate today to hear an update on this topic. I'll stop there and turn it over to Dr. Moutier.
Thank you so much, Dr. Caramelli, and also to Dr. Unitzer for inviting me. I understand this is the first of your Grand Round series this year, so I'm honored to be joining you, and also to be honoring this named memorial lecture for Dr. Ripley. So hope to do justice to all of that, and really most of all to make this time relevant for your interest and for your practice. So in order to do that, I really invite you to interact during the session by putting your comments and ideas, thoughts and questions into the chat. I really enjoy that. I learn as much from you all to hear what's on your mind. And so with that, let's get started. Here are my disclosures, and really just to say I work full-time at AFSP. So I'm fully entrenched and dedicated to suicide prevention at the national level. AFSP is the leading private funder of all suicide research. We advocate for policy change at the federal and state levels as well. And we produce programs that get dispersed through our chapter network. So I'm blessed to work in a science meets grassroots, lived experience and loss kind of arena. It's a very powerful place to be related to culture change and reducing stigma. I did publish a book on suicide prevention last year, and in the next hour, or really I'll try to keep my comments shorter so we have time to interact, I'll be going over some trends, really pre-pandemic, but also during the pandemic and where we are now in 2022. I'll talk about an innovative initiative we have at AFSP called Project 2025. And the last part of my talk will be on innovative suicide prevention strategies at both the clinical and community levels. So this is rather ambitious, so pardon me for kind of flying through some of this material, but just reflecting on the moment that we're in and that we're sort of have been in for the last couple of years. This is just a smattering of highlights of just really actually some of the concerning impacts of the pandemic on our population at a national level. And of course, what this means for each person and what each family or community are different aspects of these types of experiences directly impacted by COVID and the virus itself, on our mental health, economically, and some of these other points are just really kind of interesting indicators of just the human unrest and the level of impact that the pandemic has had in sort of upending our even just the most basic normal senses of security, and how that affected our body and brain and sort of human behavior at a population level. Additionally, although this talk is not geared towards that really important topic of clinician suicide prevention for ourselves and our colleagues, I also do think about sort of the double whammy that all of this means for us as clinicians, and particularly those who are frontline facing this degree of distress and unrest. We also know that it's a time that mental health has been affected quite ubiquitously, and that there have been particular concerns on certain populations, either because of pre-existing health disparities or marginalization that has been, historically and long-standing, but now accentuated by the pandemic. And we also have seen real reasons to be concerned about youth as another specific population. I'm sure all of you saw that the Surgeon General used a public advisory warning that he told me he had not used in his previous 4-year tenure ever. So it's really reserved for very urgent matters where action is required, both at a policy level, at clinical and community level. And that was on protecting youth mental health. Similarly, the American Academy of Pediatrics, ACAP, and the Children's Hospital Association declared a similar state of emergency for child and adolescent mental health. And before the pandemic had been upon us, the Congressional Black Caucus already had convened around the topic of Black youth suicide and mental health. And you can read their report called Ring the Alarm that was chaired by, at a content level, by Dr. Michael Lindsay, who is a phenomenal scientist and academic leader. And we're fortunate to have him on our national board at AFSP as well. A couple months ago, we took out a full-page ad in the New York Times to call the public to action to demand more for mental health. And this was at the start of May, which was Mental Health Awareness Month. And what I will tell you is that at the policy level, during the pandemic, there has been more readiness. It had been growing for some years. We had noticed that, mental health and suicide prevention are two of the very few remaining mostly bipartisan issues where anytime a bill is raised, depending on all of the details of the content in them, we tend to get very full bipartisan support. And so that has meant some incredible changes with regard to the level of appropriations, funding, mental health. Parity is now getting enacted at the state level. And for example, the 988 new crisis response system that's being sort of rebranded, but also as an opportunity to build all the layers that have been missing across the United States, various communities. The public's interest and attitudes towards mental health have been changing dramatically. We've been surveying the public every 2 years through a Harris poll. And in the most recent one that actually just completed a few weeks ago, we've seen all of these metrics in attitudes and destigmatization becoming even more positive. So, for example, it's now 96% of American adults say that their mental health is as or more important than their physical health. So really a deeper understanding that mental health is part of human health and affects our lives in critical ways, just as our physical health does. Most Americans say they would want to do something if they knew that someone in their life is considering suicide. That was around 95% would want to do something, but a large majority of them said they would not know exactly what to do. So they need some knowledge and training. It's also a time when a measure of stigma reduction and also an accelerator of stigma reduction is the fact that many people in all walks of life and places, but including people who are well-known celebrity figures, athletes, et cetera, are talking about their mental health or suicidal experiences, or having lost a loved one to suicide, or all of the above. And these are just a few examples of individuals who've done that in the last couple of years. In the healthcare arena, many of us are also speaking out about our own lived experience, meaning that we either have a mental health condition, that we've experienced various aspects of, trauma or mental health changes, struggling with addiction, and how we've addressed that through treatment, support, peer support. And, if you plug into certain social media folks and follow some of this, it's actually a very uplifting and powerful experience to be part of a community that can speak so openly with one another and support each other. Similarly, stories of lived experience are being published in journals like the New England Journal of Medicine. This one pictured here is a trauma surgeon, Dr. Michael Weinstein, out of Philadelphia, who told me that after he published this incredibly intense story of his mental health journey, which included hospitalization, and really having to transform his own career path. He told me that he received nothing but support from the surgical community there in Philadelphia, in his academic medical community. And he actually has moved now into a new field of clinical practice, which is addiction medicine, as it turns out. But there are numerous stories like this that are, I would say, as important as the science. I mean, you have to start with science so that we have answers. And then I think as light is shed on these formerly stigmatized, mysterious topics like suicide, then it opens up a whole avenue for advocacy and speaking out. When I think about the pandemic, and Dr. Saramelli did mention that I published this paper, it was an invited paper in JAMA Psychiatry in October of 2020, which almost makes me shudder, because I was asked to write about the impact of the pandemic on population suicide risk. And at that time, we had no data in terms of actual suicide rates. Now we do, and I'll show you that in a moment. But what I wrote about in that paper, and I'm also part of an international group of suicide folks that represent 42 countries. And we've been meeting monthly since the start of the pandemic. That's organized by David Gunnell and some other folks abroad. But it's been amazing to come together and look at every ounce of data that we have coming out of every country, where whatever can be, whatever surveillance systems are in place, which are not terribly sophisticated in some places. And in the United States, it still lags way behind, and it still has some, major room for improvement. But to show that in most instances, other than a couple of exceptions, suicide rates thus far have not gone up. Now that's not true across the board in those 42 countries, but I'll show you again for the US in a moment. In fact, and we know that for India, for Japanese women, there were early rises actually in suicide rates, but for most other countries, there were not significant rises, and in fact, some declines. And what we've been thinking about as a group, and then what I wrote about in that JAMA Psychiatry paper, were the sort of buckets of experiences related to the pandemic, like people with pre-existing mental illness having exacerbation of their mental health, those who would go into a suicidal crisis during the pandemic and what resources would be available to them, and then the issues of financial stressors, especially during lockdown, domestic violence, the increase in alcohol consumption, loneliness, isolation, access to lethal means, which is, this is a time when firearms purchases went way up, and first-time firearms owners doubled during the pandemic in the United States, and irresponsible media reporting. So those buckets are all areas where there's a syncing up of what was happening in the pandemic period and what could theoretically and potentially press on known categories of risk factors for suicide at the population as well as at the individual level. And so here I've just given our country just sort of a little bit of an informal grade, if you will, in terms of how well we've responded to this point to these various potential worsening of suicide risk factors. I gave irresponsible media reporting kind of a weak green check because we work with a lot of media outlets, and many of the best ones are really trying and have made significant strides in their sophistication with safe and effective media reporting around suicide. In fact, to say that some of our own and my personal opportunities came because at a time when, for example, Kate Spade and Anthony Bourdain had died by suicide, when there was clearly a potential for contagion effect based on the typical way that media might message, highlighting method and graphic details and so forth. Some outlets, and including CNN, because the CNN team was personally impacted, they had known and worked closely with Anthony Bourdain, and that really was what spurred on the CNN town hall called Finding Hope that I was fortunate to be a part of helping them shape, and then was called Anderson Cooper's Anchor Buddy. So, that's a neat experience, and of course, it's not across the board that good things are happening in media reporting. Just to explain the sort of like weaker green check there. So this is just showing national suicide rates in our nation going all the way back to 1980, and forgive me for the long timeline here, but just to show that there was a downgoing trend, and then unfortunately a upgoing trend for 2 decades in a row from about 2000 to 2018, when we saw then in 2019 and again in 2020 for the early part of the pandemic, 2 downgoing years in a row. So of course we are encouraged by that. However, we also know that does not tell the full story of what's happening across each state, nor for demographic populations. So we know that the greatest burden of suicide still to this day is in white middle-aged males. And that is a group where we've seen downgoing trends over these last couple of years. But for example, for Black males, Hispanic males, and multiracial females, their rate of suicide went up in 2020, as well as for young adults 25 to 34 went up by 5.6%, and for youth went up insignificantly, but the bottom line is it didn't go down like it did for the overall national rate. Oh, I'm sorry, and here I've outlined some of those age groups so that you can just see that, for example, that brighter blue line there in the middle, that's 15 to 24-year-olds. So again, you can see their rate did not go down from 2019 to 2020. Whereas for the purple line at the top, that's the middle-aged 45 to 54-year-olds. You see how there has been a downgoing trend for them. So suicide risk is really obviously a complex outcome, but for each individual and then each community and each demographic group, there are sort of different aspects of risk and protective factors pressing upon all of us at different times. So let's get into now addressing suicide risk as a health outcome. And I'm going to take the sort of prerogative, I guess, of summing up a very complex body of literature into a couple of slides. So forgive me, because I know I'm speaking to a very educated audience here. We know that suicide risk is complex, and there are multiple risk and protective factors interacting in any given individual as in their path to suicide risk. And this is a highly dynamic, interactive situation between biological, psychological, social, and environmental risk and protective factors. And then there's current life events that are happening, which absolutely can intersect with those other, usually longer standing risk factors. The access to lethal means is an important and critical part of suicide sort of risk assessment, if you will. But the main point here is that suicide is not a one cause effect phenomenon. Really, the literature is very consistent about that it's multifaceted, that it's highly dynamic. And just to get into some of my sort of favorite scientific findings, especially to share with the general public, are that mental health is obviously critically important, and mental health conditions are a very common and potent risk factor, but that they're not the whole story to suicide risk. Similarly, genetics play a role, but do not determine destiny. We know that epigenetics are a real phenomenon for many things, including suicide risk and protectedness, meaning early trauma can change the way a person's DNA is expressed towards greater risk for suicide. But similarly, getting therapy and treatment and peer support can actually change the way genes are expressed and the way that then a person's suicide risk can be mitigated. We know that the timing of acute risk tends to be very short, minutes to hours, but that the lead-in to suicide risk is oftentimes very long, a much longer path, albeit dynamic, meaning waxing and waning. But at the moment of that acute period of risk, there is a known phenomenon of cognitive constriction or so-called tunnel vision, where even what studies show is that for people who go on to have suicidal behavior, even preceding that moment of acute suicidality or suicidal risk, even preceding that, their brains may function a little bit differently in terms of going into that more rigid binary mode more quickly or more readily. So it's sort of a difference in stress response, if you will. Cultural factors matter a lot in terms of how we handle our suicide risk, suicidal ideation, and mental health needs, whether we can seek help, talk about it, receive treatment. There are studies around the world that show that these cultural beliefs about help seeking and stigma associated with mental health conditions and experiences are associated with different suicide rates, even, for example, in different areas of Hungary where the suicide rates vary. Shame, humiliation, and despair matter in the suicide pathway. And I would just add that for us as physicians and other health professionals, may play an extra role because of our identity as seeing ourselves as caregivers, and how sensitive we are to the potential threat. So shame and humiliation play a huge role for many, many people, but thinking about health professionals in particular, our job and facing job-related concerns or malpractice and things like that can be a tremendously vulnerable period for a health professional who has some other risk factors as well. Again, it's not one cause, but I'll just maybe pick out one more thing here to say, which is that suicide contagion is a real phenomenon. I do think that the general public may have gotten a little bit confused, and actually some primary care folks as well have maybe known sort of vaguely that suicide contagion exists, and they might have conflated that with the issue of asking someone directly if they're having thoughts of suicide, perhaps conflating that might be dangerous. And they are very separate things. Asking someone about suicide, this group I'm sure knows there are at least 4 studies that show that is not a risk-inducing thing to do. In fact, it tends to be very helpful for people who are having suicidal thoughts. And for those who aren't, it doesn't introduce, suddenly they are having suicidal thoughts. That is not consistent with the research on that. And there are lots of things going on with regard to suicide screening and risk prediction. When I first came to AFSP back in 2013, our scientific council was just convening around what is really like this. The science has been growing for suicide risk and prevention, but where are the gap areas that if we, as AFSP, put out an RFP for, that maybe could make the biggest difference? And so the first focus grant, we call them, our bigger grants, RFPs, is dedicated to short-term risk prediction. And there's been quite a lot of movement and excitement on that. Although I think if I were pressed to give a statement about where we are with short-term risk prediction, what I would say is we're not quite there yet. We are getting close with the use of kind of multimodal clinical assessment alongside AI types of modalities to look at other data points in the electronic health record, or even in naturalistic and behavior patterns through ecological monitoring by wearing smart wrist monitoring devices, and even like monitoring social media behavior and things like that, but not quite ready for prime time. Although you may know that health systems like the VA have already launched programs like ReachVet that do use an AI system looking at some 130 data points in the EHR that will tell a clinician or the suicide prevention coordinator when it's time to do the active reach out, which is really interesting. And they finally published a first really positive paper showing that might be, in fact, reducing suicidal behavior in a high-risk population of veterans who are patients at the VA. So what all this sort of complex science tells us in its most simplest statement is that while complex, suicide is a health issue. And that is really a sea change in terms of how the public can understand and take out judgment and all of those things of the past where cowardly and spiritually flawed or weak, all of those things that do not fit with the science at all. And in fact, we do have an important call to action in our lexicon. We need to take out the phrase commit suicide from our wording, because we don't use the word commit for any other health outcome. And it does continue to perpetuate that myth around suicidal behavior or suicide risk being somehow linked with, again, a morally reprehensible or spiritually flawed scenario. None of that, again, jives with the science. So we recommend plain language like died by suicide or ended her life, killed himself. Those are all considered fine. The Associated Press style book listened to us and many other advocates and made that change in their official recommendations to journalists several years ago to take out and not use the phrase commit suicide. In clinical circles, let's all be very mindful of our language to not inadvertently use judgment-laden language like successful and failed attempt or a manipulative gesture, which I know we might mean it in a certain way, but as many of us know, our clinical work, and especially during training, we are really our selection bias is seeing people with more recurrent chronic suicidal behavior, more of the time with high levels of comorbidity or personality disorders, and it can be turned into sort of a pejorative situation. So I would just caution against that kind of language. It's also kind of sometimes not very specific to use language like gesture. And so if you do use it, just maybe explain what you mean if you've done kind of an actual assessment of the level of lethal intent and so forth. So since we can view suicide as a health issue and a health outcome, we can apply the public health framework to suicide prevention. And part of the public health approach is to make sure that they're universal, selective, indicated treatment and recovery spanning the full layering. We consider that upstream, midstream, and downstream approaches to suicide prevention. But in an analysis of several countries that had implemented their suicide prevention strategy, several countries rose to the top because they had, and there are countries where it's a little bit easier to control things too, countries like Denmark and Sweden, where full implementation of their suicide prevention national plan led to reductions in their national rate of suicide. And they had many things in common, but one of the things they had in common was a robust crisis response system. And that's why I'm showing this 988 logo here. Hope has a new number is what Vibrant has called it. And we at AFSP, along with other groups, have been calling Congress to action on 988 for several years, and have been thrilled to see the Congressional Act passed, but most importantly, to see the funding come forward that will now allow states to states actually have to pass their legislation in order to take fees out of their telecommunications fees. And so this has been a whole, sort of new level of coordination, and I would maybe overstating it, collaboration with the FCC to implement 988. But if the states can collect those fees, those telecoms fees, they will have an ongoing sustainable source for building the multi-layered crisis response system that is missing in most communities. So of course, staffing 988 is the first step, but what many communities don't yet have are mobile crisis teams, peer support that can actually serve as an interim. We're looking for ways so that people are not just sent to the ER to be hospitalized or with basically nothing or treatment as usual, which is sort of like waiting and getting on a waiting list. We need to build that multi-layered. And so that's one of the reasons that 988 is so very important. It is not just a rebrand of the National Suicide Prevention Lifeline. Okay, let me move forward here and talk about Project 2025. And the way that Project 2025 fits with everything that I've been talking about so far is that it's an innovative, I would call it, action plan based on the evidence that looks to speed up the translation of what is evidence-based into practice to reduce suicide rates the quickest. And so the goal is really to, we launched Project 2025 actually in 2015. So it was a 10-year horizon looking to reduce the annual rate of suicide in the US 20% by 2025. This is a very audacious goal and project. And actually, when I first came to AFSP, I was kind of surprised that something had not already been done at a national level in the US. But, that was my own learning curve with where we were with scientific inquiry and translation and implementation. And so what we did with Project 2025 was to convene experts and then a dynamic systems modeling group that does this prediction modeling for the DoD, and came up with a path forward, which was to look first at the burden of suicide, who are we losing to suicide each year? How are we losing them? Where, what settings are they passing through? What are the actions that are not implemented that are evidence-based, that if we were able to help the industries that were identified, scale them up the fastest, that we could save more lives quickly. And so what I'll just highlight here, because I've said a lot of this already, is that step 2 then was to really look for the partners, because it's one thing to be sitting in our little national space of suicide prevention and science, wagging our fingers at, the rest of the world that needs to be implementing suicide prevention. And it's another thing to partner with the leaders of those industries, hoping that they will adopt and own their role in suicide prevention, and that the continued partnership will help flow through a more rapid and large-scale change that is more deep and real, rather than a checkbox experience like we sometimes see happen in suicide prevention with partnerships. So, and the intent is also that we're measuring the scaling up and any outcomes that we have to be kind of pivoting in real time. So the 4 focus areas of Project 2025 are listed here. And of course, EDs are part of health systems, but because they have a special scientific literature around emergency department suicide prevention, they were pulled out as their own strategy, because we could sort of calculate exactly what would happen with universal screening, safety planning, lethal means counseling, et cetera, and corrections as well. And the firearms means we did something rather, I would say, innovative and perhaps controversial in the beginning, was that we were looking to infuse suicide prevention education. So it's really that universal first step of the public health model into and alongside firearms owning communities, which because of the political climate in our nation we've been so polarized around these issues, lots of kind of hostile positioning, that once we went to actually form our partnerships, we actually learned a lot from gun owners and trade associations, and of course they maybe initially, to my surprise, were just so ready to implement, because many of them, like many of us, have been touched by suicide and wanted to be involved, but were kind of in that state of paralysis like we had been. So here are some of the just top line rationale as to why these pathways were chosen, or these key areas. Obviously, the slight majority of our suicides each year in the US, the method is firearms, and the presence of firearms in the home does increase risk of suicide. And so it felt like that education was a clear path forward there to try to form some partnerships. And in fact, there had been a precedent in smaller ways with the New Hampshire Gun Project. And we learned from Kathy Barber at the Harvard School of Public Health about her work, and she helped us build that program of that approach. In health systems, we know that many people who die by suicide had been seen in primary care or in other health parts of the health system in short periods of time before their death. And also, we knew that science was giving us some new interventions to employ in these settings, similarly in emergency departments. And correctional systems was probably the most kind of like, in a way, out of our reach, because AFSP hadn't had a big, tie to the correctional systems previously, but we knew that suicide is the leading cause of death in jails, and was increasing in prisons. And we had heard from some corrections experts that the lawsuits that they face and the public pressure that they face after suicides in prisons was one of their motivating factors. So we've learned a lot in these, 7 years so far, and we are seeing some uptake that's very hopeful. So in the firearm space, this is just showing some of our partners, the VA, the National Shooting Sports Foundation, and Everytown for Gun Safety. So we really tried to be Switzerland and work across the aisle, but also specifically, we needed NSSF to have legitimacy in going into gun shops and gun ranges with our programs and materials. And that's been very successful, actually. In the health system space, we've had wonderful work with the Joint Commission, Tony Pisani's group, Safe Side Prevention, which is a training program for primary care, the American Academy of Pediatrics, which I'll go into a little bit more in the moment, and with the Institute for Healthcare Improvement, which we're just about to embark on a big scaling initiative with. And then in EDs, we've partnered with ACEP, and in the corrections space, the sort of equivalent to the Joint Commission, the accrediting body for correctional systems, is NCCHC, the National Commission on Correctional Healthcare. And they collaborated with us to produce a national, they call it a National Suicide Response Plan for the correctional systems. That document is beautiful, but we now need to really try to find ways to implement it into jails and prisons. And actually, by the way, the correctional pathway does include the lead up to incarceration and the transition beyond. It's just the correctional space has proven to be so very complicated that finding the lever points that would produce wide, broad scale implementation has been a bit of more of a challenge. So actually, if you know anything about that space, would certainly welcome a conversation with you. So clinical strategies and suicide risk reduction. Again, I'm going to fly through this because I know this is a department and with your chair that is sort of leading group with regard to the science around this. But we do have some new interventions. And so one thing to say to us older clinicians is that if you trained more than 15 to 20 years ago, we didn't have most of these that I'm going to show you. So don't feel like you kind of blinked and missed something here if you weren't aware of some of these things. So to start with, we have psychotherapies that have now been studied and or developed specifically with suicidal thoughts and suicidal behavior in mind. And that's a very distinct difference than tagging on suicide as an outcome after a study has already been designed. And so if you apply for an AFSP grant, you're going to notice that that's one of the first steps, is to really design with suicidality and suicide outcomes as your primary outcome measure, which all of these types of therapies did do, in fact. So CBT, DBT, certain forms of family therapy, and CAMS all show some positive results. CBT and DBT for actually reducing subsequent suicidal behavior in very high-risk populations. Attachment-based family therapy and CAMS is more about reducing suicidal ideation so far in terms of their studies. And medications is a whole big topic unto its own, but I will just say that lithium clearly has a big database showing that suicide risk is reduced, both ideation, behavior, and mortality. Clozapine is still the only FDA-approved medication, albeit for schizophrenia, people with schizophrenia and suicide risk. And then antidepressants do have a database that does show not only symptom reduction and mood stabilization, but some positive associations more on a pharmacoepidemiological level, being associated with the more prescribing of SSRIs, for example, in 7 different European nations and the US, even county by county in the US, are associated with declines in suicide rates, which is probably very different than what many people assume because of those black box warnings, which unfortunately led the public and many people in primary care to assume that they are more risky than they are good for suicide risk. So in the health system, and I mean that very broadly, I mean clinical health systems, I mean the payers, CMS, all of the different aspects to a health system. If you think about all of the clinical targets for safety and quality improvement, it's only been in recent years that suicide has even been viewed as a clinical focus. So I know that many of you have been seeing it as a clinical focus for many years, but I'm talking about, in the more broad health system space, including for primary care. And so I've already mentioned that many people who are at risk for suicide are being seen for lots of reasons. They don't necessarily declare their suicidal thoughts or their mental health concerns, but they're passing through EDs and primary care without their risk necessarily getting recognized. And of course, we saw the Joint Commission move ahead with their national patient safety goal several years ago that does require suicide risk screening of all patients being treated for mental health concerns in all health settings. So that means in primary care and in EDs. But the key there is when there's a mental health concern that's been recognized. And of course, in behavioral health settings, it's all patients actually are required to be screened for suicide risk. In 2018, I would say that marked the moment when there was consensus or relative consensus in the suicide prevention field to call out the minimum steps that could be taken to screen and care for people who screen positive in primary care, in emergency departments, and in behavioral health. And that's how they've organized this document. So please do check out this document if you've never seen it. It lays it out kind of very, very simply and clearly. And there are many things that health systems can be doing to make suicide a quality and safety metric, and to have continuous quality improvement around that by changing their policies, protocols, workflows, providing education to all staff. And I say that because we've seen the benefit of not only training clinicians, but training the admin staff as well, because they play a role in how the workflow goes. And when patients call, for example, or things like that, all the staff need to know what to do. asking for consent to involve the family at the start of treatment could play a very key, important role in suicide prevention, because then once you reach your moment of suicidal, risk increasing or crisis, of course, you can re-ask the question, but you might already have some familiarity with who is in their life and how might you be able to speak with them in terms of the implementation of safety planning and lethal means counseling, for example. Ideally, that's done. Ideally, that's done with the patient, and even more ideally, that's done with some family member involvement. And then, of course, when family members are safe and allowed for by the patient. And then documenting all of these actions that you take is part and parcel to our work, of course, and it is a way that we also make sure that our own medical legal liability is protected maximally. But these are the steps that I would say both help your patient and reduce their risk the most, and also by documenting all of these that you can be mindful of your own risk. And I say that only because some people who aren't sure, their anxiety looms large, and particularly about liability. Brief interventions, I've just listed them here. Safety planning, lethal means counseling, of course, giving. So this is really, these are interventions that can be done in an emergency department or in primary care. And of course, they can also be done in behavioral health settings. But the caring contacts literature, in case you aren't familiar with that, is now, I think, up to 16 studies, 13 of which are positive, showing that a series of postcards, emails, text messages, phone calls, or in-person visits for high-risk individuals who most of the studies are when they're being discharged either from the ER or from inpatient psychiatric hospitalization. And when those folks get those 8 to 12 series of communications compared to the treatment of as usual group, subsequent suicidal behavior is reduced quite a bit, in some instances between like 40 and 60%. So don't underestimate the power of instituting something that's even automatic that your health system can put into place. Okay, I need to kind of fly through the rest of this. My apologies. Get excited about some of this material. Our partnership with the American Academy of Pediatrics so far has produced this document we're very proud of called the Blueprint for Youth Suicide Prevention. It lives on the AAP website, and it has a clinical, community, and policy sections. Some new data out of NIMH, Lisa Horowitz's group, shows that at least for kids, screening that has to go first through the PHQ or item number 9 is possibly going to miss some instances of kids who actually would have screened positive on the ASQ if they were, just first screened with the ASQ. So this is a group of 600 medical surgical pediatric inpatients. And out of 681 of them screened positive on the ASQ. And I'll show you what happens if you just did the PHQ, then 32% of those who screened positive on the ASQ would have been missed. And if you just used item number 9, 56% of kids screening positive for the ASQ would have been missed by just item number 9. So that might seem very kind of surprising, because item number 9 is known to be like the suicide item. But the fact that it doesn't ask about, it asks about wanting to hurt yourself and more passive thoughts of death or dying. And there's probably other reasons too, which in kids, let alone in adults, it's not all depression-based. Suicidality comes from many different risk buckets, like we talked about before. I'll just fly through some of the community-based approaches. So what I'm about to show you very quickly are some visuals that just give you a snapshot of what I would call universal suicide prevention education, that our chapters are helping to spread across communities, faith communities. We have I call this our Suicide Prevention 101 presentation that our volunteers are getting trained to give, called Talk Saves Lives. And it's been so popular that it's now been customized to LGBTQ populations, to correctional facility staff, for older adults, for Latinx communities. We're customizing programs for Black churches as something that's happening right now, piloting and about to launch on a more national basis. We partnered with a group that has Gizmos Possum Adventure, which is a guide to mental health for 2nd to 5th graders, looking for something for younger children that doesn't go to the topic of suicide, but really helps them more of a social emotional learning type of curricula, but really with some key steps where they connect with a trusted adult, establish, some little important milestones for managing mental health at that age. For those of you who weren't aware, schools are very, very engaged, or they should be, in suicide prevention. And we partner with other organizations to produce this model school district policy on suicide prevention to help schools with language and templates. We have this ad campaign with the JED Foundation and the Ad Council targeting 16 to 24-year-olds that is now in about its 4th year. And Ad Council tells us that 52% of that age group have seen this ad campaign, and that's because people like Billie Eilish and others have used it, spoken to it, and talked about their mental health as part of the Seize the Awkward campaign. We're very grateful to a whole host of young people who've taken an interest and really helped push it out. Workplaces are now initiating suicide prevention activities. And a very groundbreaking thing, in my opinion, happened last week when we had the privilege of partnering with OSHA. That had never happened. OSHA had never seen suicide as a safety issue in the workplace. So as our federal government's Occupational Safety and Health Administration that also has regional branches, they'll be pushing out messages like this poster that we helped them create. To give you a sense of how far afield from the mental health world suicide prevention is now, you can see that we have partnerships with groups like the Associated Builders and Contractors Trade Association. This is the biggest trade association in the construction industry. Our partnership with Netflix and Instagram and Universal Music Group certainly doesn't mean that they're doing everything right. And, none of us are doing everything right, but it is a learning journey, and it is getting deeper and deeper with most of these. Again, we really try to avoid the superficial, checkbox type of partnerships. And maybe I'll just close by talking about postvention just for a moment. After a suicide occurs, there's a key pivotal moment where we must, and especially as leaders in an institution or a school, or a community, where if we message and convene the community in certain ways, we can facilitate healthy grieving and try to mitigate any aspects of contagion risk that can in fact occur after a suicide has occurred. And our original After a Suicide Toolkit for Schools has now been customized for medical settings, for veterinary medical settings, and we're doing that now with the construction industry as well. So some practical takeaways before I close. We all have a role to play in changing societal norms and knowledge to deepen mental health literacy and advance suicide prevention. And we're really seeing that taking off, and are so grateful that that the science is growing, but that the public's readiness has kind of converged. And I think our chapters and the Out of the Darkness walks have helped play a bit of a role, as of course we all do, and you all do as well. We do need sustained, comprehensive, multi-sectorial strategies to really do the most maximal work that we can for suicide prevention. It is true that we as clinicians and health systems, but also loved ones, educators, faith organizations, and certainly the crisis response system all have a role to play in this sort of multi-layered public health approach to suicide prevention. And Project 2025 is a national implementation project aiming to broadly scale these effective interventions to reduce suicide the most quickly. Here are some of my favorite resources, and I do have a handout on this as well. Can make sure that is provided to your department. And there's just a picture of my book where I tried to sum up a lot of the stuff that I am speaking to you about today. So thank you so much. I'll end my comments there.
Thank you, Dr. Moutier. What an informative, interesting presentation going through what's been done already, visions for next steps. I mean, we do have a couple of minutes for questions, comments. If any participants have a question, please write it in. We could go through it. I haven't seen any come in yet. Just one observation. I mean, one of the things I was struck by was the prevention efforts are often immediately linked to something that somebody can do, not just clinicians, but like the OSHA handout that you showed. It tells people what to do. Here's a suggestion for a question to ask. How, it's moving a clinical process, so to speak. I mean, was that intentional? Was that what's most effective generally? Yeah, I'm curious about that.
Yeah, I mean, we found, well, I'll go back to when I was doing the work at UCSD to try to address the suicides that were happening tragically amongst physicians at UCSD. And Sid Zissik and I started a program. And what we learned after the first year of like giving 30 grand rounds on the topic, very, kind of academic and data, is they wanted us to come back, but they wanted us to give them language to say. And what do I say if I'm worried about a colleague? And how do I pose the question if I'm worried about a patient? And so maybe surprisingly, but I'm not surprised anymore by it, that's how much stigma was presenting a barrier for us, that just knowing, having some language has been very, very important. Yeah.
I mean, people are writing in with very positive comments, appreciating the depth and quality of the presentation, clearly. I guess, given that you're here, about a question came in about educational materials, develop educational and support and videos for clinicians with suicide loss, wanting to develop a small grant in the area. Yeah, what thoughts do you have about that?
Oh, that would be fantastic. And I see that that's Kate Comtois, who is an expert herself, as well as Julie Richards. So thank you so much to both of you. That would be phenomenal. The issue of clinician suicide loss, and I'm assuming this means for when clinicians or a team loses a patient to suicide, more so than, okay, yes. That is a huge need, and one that has only been, I think, tackled kind of piecemeal, if I really had to say bluntly. I mean, there's some wonderful resources that you probably know about. A video that Joan Anzia, Glenn Gabbard, Sid Zissik, and other folks made, but it's now probably, it's probably, 12, 15 years old. We also at UCSD had put together a whole bunch of resources. I think it's time for a new set of like maybe readings, a video that could be used in educational presentations. I think it's a wonderful idea. And I'm sure you have access to all this, but if you need to see at least my version of everything that's been done so far, we keep all of that upon request. It's so silly. I don't know why we haven't gotten around to kind of having it packaged up, but probably because it is a little bit piecemeal and getting old now. So I love that idea.
Well, this is a nice outcome from not only an informative, excellent presentation, but also pushing an idea forward. Two great outcomes here. So, well, we're just at 1 o'clock here. And I do want to, again, thank you, Dr. Moutier, for presenting today, for joining us for the start of our Grand Round series. And thank you to the participants today for attending.
Thank you so much for having me. Take care.
Right, take care.
My best to everyone at UW.
Thank you. Bye.